First of all, good day to all colleagues. I would like to express my gratitude to be here with you today and of course to send you warm greetings from Belgrade, from the University Children's Hospital where I work, in front of the head of our department, Professor Irena Simic, whose lecture I will represent today. We have the same family name, but trust me, it's just a coincidence. I will try to tell you her lecture on the way, not that you can read in book. I will try to communicate with you, to be honest, to say I to you and you to me what you are really doing in your everyday practice and to see where we all are in this relation, how we do the procedural anesthesia or analgesia or sedation for our small patients.
Насамперед, Irena Simic, доповідач, хочу передати привіт з Белграду, з університетської дитячої клініки, особливо від голови відділення інтенсивної терапії Irena Simic. Як сказала, вони однофамільці, але ніякого, просто однофамільці, ніякого спорідненості, родства ніякого немає. І також хочеться зазначити, що приведені дані є не книжковими даними, тобто це дійсно застосовується, і Ірена прагне живого спілкування з вами, тобто прагне комунікації і
Okay. Unfortunately, if we want to be honest, this was the model for the pain treatment for a very long time. Be brave, it will be short, it will pass fast. Am I right? Even now, today, we can very often hear these voices from us doctors to our little patient when we should, for example, insert the needle or to take a blood example. But there are really a lot to think about.
Ну, насамперед хочеться зазначити, що для лікування процедурного болю ми зазвичай просимо дітей або бути більш хоробрими, або потерпіти цю процедуру, але це неправильно, тому ми можемо і маємо щось робити.
We should work together with our colleagues. Either we are talking about surgical procedures or some diagnostic procedures with our colleague radiologist. We should offer them circumstances to do their job, diagnostic procedure, for example, radiologist or endoscopy or surgical procedure, laceration, repair or something like that, to be safe and effective. And of course, we should reduce the emotional distress and acute pain in children. Of course, we should enable the procedure performance and enable amnesia and reduction on consciousness. If you ask me when we are talking about the procedural anesthesia, maybe this one, amnesia and reduction of consciousness is a great thing. I am very happy when I come the day after and when the child look at me and say, I don't know who you are. So that means that you did a good job.
Насамперед маємо використовувати контроль болю при виконанні терапевтичних та діагностичних процедур для забезпечення для ефективності та безпеки вирішення особливо емоціонального дистресу, також гострого болю дітей під час виконання цих процедур. Також ми маємо вирішити питання про забезпечення амнезії, а також зменшення свідомості.
There are many indications for pediatric procedural sedation. I think that for this we doesn't need translate. This is something that you are obviously do every day, talking about urinary catheterization, lumbar puncture, radiographic evaluation, joint aspiration, unfortunately more often sexual assault examination, eye examination, especially in low weight preterm babies, therapeutic IV line, laceration repair, abscesses, incision and drainage, fracture reduction. For example, while you are on duty, on fully stomach, I think that we all have such situation, dislocation reduction, foreign body removal and burn dressing. No need for translate this. Are you agree?
Покази до
Okay. I was very surprised when I see this fact. I must admit that I wasn't aware of this, although I am working with children more than 10 years, that in our everyday work we have 141 procedures, especially in the intensive care unit, that we are doing under our small patients. And average for 1 day per day we do 16 of them. And look this is awful, but this is true, and we have to talk what is true, not we should hear. Almost 80% is without analgesia. Only 20 is with some kind of analog sedation. And if you have to perform 153 tracheal aspiration or 95 heel stitches during the 2 weeks of medication in the intensive care unit, then it is really an awful number.
Ірина привела на її погляд жахливі дані, не тільки на її погляд, що особливо в новонароджених дітей при виконанні 141 процедури лише 20% з них забезпечується седацією, а 80% виконується без аналгезії.
Basic rules. You have to plan the procedure and to think always, is it really necessary for that what you would like to do? For example, if you want to insert the central venous line, or if you want to take 5 times during one morning blood example, because first we wanted just to see check the blood levels, and then we remember that we forgot glucose, so take another time. And after 10 minutes the chief will come and ask, did you get a blood analysis? Take once again. Are you doing that? Have you those situations? Be honest, please. I have in my everyday work. So in the morning, please, try to think about it. Try to plan the procedure and avoid repetitive actions. And of course, if you can modify the procedure to be painless. This is something that we all know. We should have a quiet, nice room, but we always not in those good condition. We have to be well educated. That is something that we can work together on. We have to learn every day. And allow time for drugs acting, and to have a reserve plan. Allow time for drugs acting. How often you were in the situation that someone else is always hurry, I have more patients, hurry up, we have 3 more operations. Is it true? My colleagues always do that. They always push some press on you to hurry. And reserve plan, you always have to think what you can do if the first solution is not good enough. At least call someone to help you.
Тут приведені основні правила для седації, тобто ми спочатку повинні планувати процедуру, чи це необхідно для лікування, чи ми також повинні уникати повторюваних дій. Як зазначала Ірена, якщо ми беремо аналіз крові і, наприклад, забули взяти глюкозу, тобто це недопустимо, треба брати все разом. Тобто, щоб не колоти дитину 2 рази, також повинні створитися кімнати, які є затишні для дитини, і тихі, спокійні, повинен бути добре навчений персонал, а також ми повинні обов'язково дозволяти, навіть якщо ми ввели якісь ліки для седації, ми повинні обов'язково дати час, щоб вони подіяли.
You can see here, we won't translate this, who should be allowed to do analog sedation during some procedures, diagnostic or therapeutic. And of course, we really have to take care that someone had at least 5 supervised sedation before doing it by himself. Like in a cockpit, the most important things are when you are starting your procedures and when you are going home or when the plane is going down. You have to be experienced to know during the induction, what and how much drug should you give, and before discharge to be sure that the child is fully awake and safe.
Ми повинні обов'язково спостерігати з дитиною і забезпечити ситуацію як ввели, так і повністю до виконану.
What is expected from you? This is something that most of you will say, I know that, but once again, to be honest, are we always fully present near the patient, or we will maybe go out just for a moment to take a little water or something like that, but for a moment when you are doing just the procedural alba sedation, many problems can cause, and of course you have to supervise the nurse of other train who is administrating medication, and of course if you are not from some other reason at the moment present here, you have to be always immediately available to come on the place where procedure is undergoing.
Що очікується від анестезіолога, від лікуючого лікаря, тобто при введенні склетинних ми повинні фізично бути присутнім біля пацієнта, також контролювати медсестер, а також інших стажерів, хто вводить препарати, і моніторувати пацієнта. А також після для відновної фази ми також повинні бути постійно присутні з пацієнтом.
We won't translate this because those are some necessary skills that we all have because we are anesthesiologists. We know how to treat the cardiovascular complication and respiratory depression, and of course we own the at least basic knowledge of the pharmacology. Either we are young doctors or we are seniors. We can go through this without translation. Is it okay? Of course, there is many studies and many written guidelines that you can always see and read if you want to be sure that you are doing your procedural anal sedation on right way. Approach to the pain treatment means that you can use non-opioid analgesics and opioid. How many of you are dealing with the children every day? Okay, so a little number of colleagues, and the most of other colleagues have very often afraid of what to give a child because there are maybe not enough routine. Just to know that you can use non-opioid and opioid analgesics further as you are experienced with them. Any of technique of regional anesthesia, which I really love and think it is very safe and good. And very important for children, maybe more than we think about, is this non-pharmacology approach. Psychological preparation, distraction, power of love, tactile stimulation, talk, calm, and hypnosis.
Підходи до лікування болю є фармакологічні, тобто можна використовувати опіоїдні аналгетики, також неопіоїдні аналгетики. Використовується регіональна анестезія, яка є більш безпечною, а також нефармакологічні методи, тобто має бути психологічна підготовка дитини, також її батьків, також має бути відволікаючі процедури для дитини, гіпноз, тактильна стимуляція, розмови.
And ways of application is also something that I think that is not needed to be translated. This is always that we do every day, but please remember this picture. The child will deny pain to avoid the intramuscular sting. I hate needles also, I am not a child. So just imagine, child will say, I'm extra, super, I don't feel any pain, just because they are afraid that they will get some intramuscular injection. No translate needed. These are different levels of sedation. We won't be on this slide too long because this is something that you know. You can have the minimal sedation with normal response. You can have the level of moderate sedation with response on command and light touch, and the airway is maintained in these two steps. Then deep sedation and analgesia with response purposefully to repeated or painful stimulation, and of course general anesthesia And on these third and fourth steps, the airway maintained is here. Here for sure it is not, but can be problematic, airway maintained. So just pay attention on airway. We don't need translate for this. No? Okay. Risk. Different degrees of mild sedation to general anesthesia can be achieved with almost all drugs. So if you have something in hospital and you are familiar with that drug, use it. Don't do things without any kind of analgesia because you don't have something. That is not an excuse. I don't have is not excuse. You always have something. Just think about it and use it. With increasing dose and drug levels in the CNS, decreases awareness and increase the risk of depression of breathing and circulatory depression. But of course, you are an anesthesiologist, so you can recognize the moment when you should maybe do something else more than monitoring the patient.
Є певні ризики, тобто різні ступені м'якої седації, від м'якої седації до загальної анестезії можуть бути досягнуті майже всіма седативними засобами, також з підвищенням дози і рівню ліків, підвищується доза і рівень ліків в центральній нервовій системі, а також може зростати ризик депресії серцевого судинності.
Of course, this is something very familiar for you, no translate need. Always you have to take a good anamnesis, physical examination, and of course inform consent. Don't forget these rules, fasting 2-4-6 hours before some procedure, 2 hours only for water, 4 hours for the breastfeeded kids, and 6 hours if they are eating. Equipment, also something that we know that always should have. The oxygen resource equipment for the airway, established aspiration, resuscitation equipment and monitoring. That's clear. Can we go further? Okay. This is something that I want to repeat because I know that you know this. After the 24th gestation of week, neonatals intrauterine are capable to feel pain, and just the manifestation depends on different degrees of development. They are of course more sensitive to the side effects of analgesia, and those are techniques that you can use because you always have that in hospital. If you have mother, you can have breastfeeding, you always have some sucking psychosis or glucosis 25%, and you can always give them some kind of tactile stimulation.
Новонароджені діти також відчувають біль, але його прояв залежить від різного ступеня їх розвитку. Також вони більш чутливі до анестезії, а також ми можемо забезпечувати, якщо навіть немає ніякої седативних засобів, мати може допомогти та заспокоїти дитину тактильною стимуляцією, грудним вигодовуванням, а також даванням глюкози або сахарозу.
Those are non-pharmacological approaches, really very important. Try if you didn't until now and you will see the result. Infant and older children, they are good for the psychological preparation. Okay? Pharmacological and non-pharmacological methods, and for usage of oxygen and this one little sedation and general anesthesia for invasive and repeated pain process. Sampling of blood, please. Look, you can take local anesthetic, you can take psychosis, and you can take baby and cuddle it with pacifiers and psychosis. Psychosis, I would like you to remember this, is something that you can give. Peros, half 1 or 2 milliliters, so you can give them before the procedural analog sedation. Sampling of blood, never without topical local anesthetic or some kind of psychological strategy. Eye examination for little babies also, again, psychosis, pacifier, local anesthetic. This is something that you are in your everyday work very often. Lumbar puncture, again please, topical anesthetic or non-pharmacological approach. Placement of urinary catheter, also vaccine, routine vaccine, also non-pharmacological approach. This is something very important. Change of dressing in children with burns. Repeatedly, very painful procedures. Always use opioids, non-pharmacological therapies, and great experience in our hospital with ketamine. Repair of laceration, something that you are doing also in your duties. This is diagnostic procedures. We are very often have it, also you, I believe, NMR, CT. We have also very often some circumstances that are on the margins of safety, so you are not safe when you are doing that, but you have to give some analog sedation if you have a small baby for the CT or something like that. And you have to be the coordinator of all those situations. Non-anesthesiologists, our colleagues, must be self-critically, and they have to ask us to make together a strategy. You see, the procedure rooms are usually not constructed for our benefit. Risk and complication always airway, hyperventilation, apnea, aspiration, and hemodynamic disorders. The reason is a hypotonia of pharyngeal muscles. And safety is something that we can take care about. Reasons of complications, once again, drug, different overdoses, or inadequate equipment, education, or inadequate our attitude to the problem. Drugs should not be given at home, please. And we should avoid premature discharge. What did I do now? Okay, sorry. Discharge should be done when you have fully awake and satisfied children. He can sleep or she can sleep. She doesn't have to talk with you like now. But this is something that is not for discharging. Patient should be satisfied, calm, and start to drink and eat before going home. What would I like you to tell? That we should always reduce pain, or at least try it in children. Of course, their anxiety also, their fear, because it is very important when you are a child not to remember those things, to be in hospital as an awful experience. Use pharmacological methods and do not overlook the usefulness of non-pharmacological methods. Once again, power of love, tactile stimulation, breastfeeding, talking, cuddling, pacifying for the small babies with glucose. You always have that. Good preparation, continuous evaluation, familiar with the resuscitation technique, and good clinical recovery before discharge. Those are rules for safe and good procedural sedation in children. Learn, ask. There is no stupid questions. It's no shame if you don't know or don't understand something. We have to talk and we have to be honest. Don't talk that you are doing something if that's not true. And always admit if you make a mistake. It's also good for knowledge. That's really serious business. And worst sin really to other creatures is not to hate them, than to be indifferent to them. Because if you really are able to look some procedures under the child without any attention to help them, then we are indifferent, and then we are devils, like here it is written, and we should be angels. And please translate this.
Тобто найбільшим гріхом для інших створінь є не те, що ми їх ненавидимо, а те, що ми ставимося до них байдужим. Це є суть негуманності.
That will be all. Thank you.